Okay, perfect.
Perfect.
We have the slides all set.
Set.
Try not to press too many buttons at the same time. Go ahead.
Good afternoon y buenas tardes. Thank you so much, Mauricio, for asking me to speak today for an update on lower urinary tract symptoms. I was going to limit my discussion only to male LUTs, but I thought I would include both male and female symptoms as we discuss our pharmacologic and treatment considerations in the current time frame. I think it's very important that we understand that our understanding of these conditions continues to progress, and there is new data coming forward at all times that we must be aware of. These are my conflicts of interest. I'm on the American Board of Urology, and I'm the editor of Neurourology and Urodynamics, and I have in the past consulted for the two companies below. I wanted to begin the lecture with a picture from Leonardo da Vinci. This is one of the anatomic codexes that da Vinci performed based upon his anatomic dissections. And I thought that this was an interesting picture because, as you notice, in the upper aspect of the right, there is the brain and the various structures of the brain and spinal cord. And interestingly enough, in the lower left is the bladder and prostate. So Da Vinci obviously understood the importance of the central nervous system for the treatment, and rather for the function of the lower urinary tract. And again, this was 800 years ago now. So obviously we continue to understand that the central nervous system remains very important in lower urinary tract symptoms. And we know that neural control of micturition is not only important for urinary storage due to suprapontine and also subpontine centers, but it's also important for emptying as well. So we think of the bladder and the function of the bladder in two phases, storage and emptying. And obviously the central nervous system is very, very important for both. For emptying, it's not only the volition and suppression of central inhibitory signals coming from the frontal cortex, but it's obviously also relaxation of the sphincter and sympathetic and parasympathetic stimulation of the detrusor. We know, as we look at the lower urinary tract, that there are several ways we can modulate lower urinary tract function. We have traditionally focused on the lower of these, that being the bladder, prostate, and pelvic structures in terms of our pharmacology and other treatments. But truly, as we now expand our pharmacologic armamentarium, we are beginning to understand the importance of the sacral spinal cord and the peripheral nerves, and obviously, as I've just mentioned, the central structures. Unfortunately, we still lack the ability to modulate the central nervous system, even though we have now significant data, especially from functional magnetic resonance imaging, suggesting that the central nervous system is important not only in normal, but also pathologic function of the lower urinary tract, resulting in not only continence and incontinence disorders, but also storage and sensory disorders. And it's very important that we keep in mind the central nervous system and its function as we continue to evolve in our understanding of the lower urinary tract. Recently, we've come to understand the importance of receptors and a variety of receptors, both locally and more peripherally outside of the central nervous system, but also outside of the lower urinary tract. And again, the importance of the parasympathetic system is just now becoming understood, as well as the sympathetic system, in terms of the mutual control of the lower urinary tract in terms of both normal function and abnormal function. Perhaps the greatest advances that have been made recently are in the understanding of the local environment of the bladder. This is a cross-section of the bladder wall. Obviously, it's a drawing, but it shows the importance of the various layers of the bladder wall. Traditionally, when I was a student, we learned the importance of the muscularis of the bladder and the innervation of the muscularis. We really did not understand the lamina propria and the importance of sensory structures in the lamina propria. And we only understood the epithelium of the bladder to be a covering substance. We didn't understand the importance of the epithelium that is now, over the last decade, 10 years or so become understood. We understand that the epithelium has a function not only of protection of the underlying structures, but also as the bladder stretches and contracts, there are release of various factors that go from the epithelium to the lamina propria, the sublamina propria of the bladder, and cause bladder sensory function as well as motor function. And the activity of the lamina propria is extremely important, especially cells, the interstitial cells that essentially form the communication between epithelial function and also muscular function. We are just now beginning to understand the receptors that are existent not only in the epithelium but also in the subepithelium. And so therefore our focus on the sympathetic and parasympathetic functions of the bladder, which are historic, now are thought to be only part of the true story. And the true story is the function of all of these layers working together to give both normal function as well as abnormal sensation and abnormal function in the circumstance of pathophysiology. One of the most important recent advances, both in male and female lower urinary tract symptoms, has been the development of combination therapy. And I'm afraid my animation is not working because you control the screen, but what we understand for a combination therapy is that we must in some way interact with the patient's symptoms and try to prevent progression of symptoms to becoming more significant for the individual by optimizing treatment efficacy, by reducing symptoms, and also trying to balance those with side effects. And unfortunately, recently we've become aware of increasing side effects with many of our pharmacologic treatments that may be problematic, may be a problem for patients long-term in the management of their conditions. So what are our goals in the management of storage disorder in both men and women? Well, there are goals that are important to us as physicians. There are goals that are important to governmental authorities. There are goals to the companies that make these drugs. And there are also goals that are important to the individual patient that we must keep in mind. And we measure these goals by a variety of outcomes, including urinary diaries, patient-reported outcomes, questionnaires. But what is it that the patient wants or expects? And these are important considerations, especially when we consider the concept of refractory urinary dysfunction, refractory incontinence, where the patient is not happy with their outcome. So the problem with lower urinary tract symptoms is that our goals, the goal of the patient and the goal of the physician, are often not aligned. And that is because many of the measures that we have used to determine the severity of bladder storage function, OAB, may not actually be in parallel with patient goals. And actually, patient goal achievement, unfortunately, shows no correlation, no connection with some of the measures that we use, especially from some of the now historic trials of antimuscarinic therapy. So it becomes very problematic, especially when we start talking about patients who are non-responsive to treatment, refractory to treatment, and what options we have for those individuals, especially if we haven't answered their goals for therapy early in treatment. And therefore, it's important now, and it's becoming increasingly important, that we understand what patient goals are so that we can optimize therapy. What does the patient ask for? Well, this was one of the first papers. There were actually two groups that described this. This was the group in Chicago at Loyola. There's also a group at King's College in London that asked what the patient's self-determined goals are. And essentially, this group looked at the patient goals before and after treatment to try to optimize therapy to determine what was most important for patients. And again, what is most important for patients, obviously, is what we should really focus on as practitioners. Patient-reported goal achievement essentially has now been established for a variety of disorders, not only for prolapse, but also for stress incontinence, for painful bladder, and obviously for many now of the lower urinary tract symptoms that we essentially are very much focused on in both genders, both men and women. And therefore, I think it's very important that as we progress the science of lower urinary tract symptoms, we understand the importance of addressing the goal of the patient in therapy. Patient goal treatments after antimuscarinic treatments obviously are, we measure those goals in terms of symptom relief, daytime frequency, urinary urgency, urgent continence, nocturia, and we use a variety of quality of life scales to help us assess the ability to gain or attain the goals that the patient has, and also perhaps to change coping behaviors. And this is an old study that looked at one of the older medicines that we use for bladder storage symptoms. And as you can see, this was a correlation between how the patient's goal assessment for treatment correlated with some of the outcomes. And there was very poor correlation with many of the outcomes that we use in our antimuscarinic and, for that matter, beta-adrenergic treatment outcome reporting in the literature compared to what patients are looking for. So again, this is very important that we understand what the most bothersome patient symptoms are and what we can do to address those symptoms with a realistic ability to tell the patient what we are able to accomplish and not able to accomplish. This was another paper, again, looking at patient goal-reported achievement after botulinum toxin treatment. And again, noticing the difference. This is looking at botulinum toxin versus placebo and looking at patient goals, reducing incontinence, reducing other urinary symptoms, reducing activity limitations, improving quality of life, improving sleep, and decreasing number of ingestions, oral ingestions. And notice when patients wanted to be dry, obviously the use of Botox was most effective for those individuals. But notice how poor the correlation was for many of the individuals, because again, we tend to think of the outcomes as individual outcomes, and the patient is looking at more of all the outcomes placed together and the way they feel about those outcomes. So again, it's very important that we understand that we must focus our outcomes, address our outcomes uniquely and individually for the patient receiving the treatment. And again, this is just further work from that paper looking at the use of Botox for neurogenic detrusor overactivity and the ability of oxybutynin versus placebo, Botox versus placebo to achieve those outcomes. And in this trial, Botox actually did overall do much better than did placebo on many circumstances. But still, as you can see, there are several areas where the outcomes with Botox were below 50% in terms of the percentage of patients achieving their reported goals. So obviously we have a long way to go to optimize treatment for patients with any of the interventions that we have. I do want to spend a few moments talking about the combination of beta-3 therapy and antimuscarinic therapy, because this is the area that is most recent and the most recent development in combination therapy for both female and male patients with overactive bladder. And there have been a variety of studies now recently published that have looked at the combination of beta-3 receptor agonist, mirabegron, plus a variety of overactive bladder medications that are antimuscarinic, either together or as add-on therapy for the benefit of individuals. And what we've seen, specifically in the Symphony study, which was one of the first trials to look at a typical group of patients with overactive bladder as compared to placebo, looking at combination therapy, what we saw was that mirabegron and solifenacin together was superior either to mirabegron or solifenacin as compared to placebo. So as you can see, their solifenacin is here, combination is there, and the combination with either 25 of mirabegron or 50 of mirabegron. And as we look at the adjusted difference from placebo, we can see that combination therapy actually provided the best treatment because it addressed two separate mechanisms of action. And this is exciting from my standpoint because as we become more and more comfortable with combining medications, we can hopefully address different mechanisms of action and hopefully improve patients' overall expectations for quality of life improvement. This was, the prior slide showed incontinence episodes. This is micturitions and urgency episodes. And again, the message is that combination therapy is superior to either agent alone, either the antimuscarinic or the beta-3 agonist by themselves. The combination is preferable and gives superior results as compared to the individual drug therapies themselves. So Also, interestingly, combination therapy is much less problematic as compared to isolated therapy. The overall resulting side effects, again, dry mouth, not unexpectedly seen with antimuscarinics, but less than we see in many of the antimuscarinic trials. Hypertension, always something we look for with the beta-3 agonist, but this is not significant hypertension. And again, there doesn't appear to be a dose relationship between combination therapy and monotherapy groups in terms of any cardiovascular signal, especially as we're talking about, or as we speak about, beta-3 agents, which, as we know, have a cardiovascular effect. Antimuscarinics have been the mainstay, the basis, the foundation for treatment for 30 years now for lower urinary tract symptoms in both genders. This is the outcome of the most recent ICUD meeting, which showed that the use of antimuscarinics in monotherapy for men was felt to have some evidence to support its use, and that monotherapy could be considered. And that was found to be relatively safe. And as we know, this is true also for women. Antimuscarinics have been used for years for the management of overactive bladder and other storage symptoms. We know that in men, antimuscarinics do add benefit to men with storage symptoms that has been previously attributed to enlargement of the prostate. Those storage symptoms are again manifested largely in most men by urgency and micturition. And as we can see, the overall advantage of sulfenacin as compared to placebo was substantial in several trials, and also much better than isolated placebo in terms of the response for patients. The problem that we have is now it is becoming clear that there's a signal that long-term exposure to antimuscarinics may cause cognitive decline and potentially put the patient at risk for early dementia. And there has now just been 2 more studies that have been published which are lending concern to long-term administration of antimuscarinics for individuals with bladder storage symptoms. This is very concerning and something that we as physicians must be aware of. And this may actually change our ability to use antimuscarinics, especially in older patients, because the data now is becoming quite striking regarding cognitive dysfunction over 5 to 10 year periods of ingestion of antimuscarinics as a part of anticholinergics used for other indications as well. Another class of agents that is very interesting are the phosphodiesterase inhibitors, which clearly don't have a muscular effect, but probably have a vascular effect. They improve vascular inflow. And we know that in a variety of trials, there has been no change in bladder ability to empty, despite the inflow of blood vessel, blood flow, which is a very good sign. So there's no effect on bladder contraction. But there does appear to be an improvement in bladder storage symptoms associated with this. And this has been clearly shown in men, and this is, again, a variety of trials that have looked at 2 of the most common, in this case, tamsulosin and rather tadalafil, but is also true for Cialis, that we've seen improvement in total symptom score across trials as compared to isolated alpha blockade in men with LUTs. Why is this? Well, it's not, again, a smooth muscle effect per se, and it probably is a sensory effect. And we now think, because of animal studies, this sensory effect occurs perhaps in the bladder, but also at the level of the sacral spinal cord. So it means that perhaps we can actually use these agents prospectively in women as well to improve vascular inflow and improve sensory disorder of the bladder, which, as we know, is associated not only with urgency, but also with pelvic pain syndromes. This is simply a most recent systematic review of the combination of phosphodiesterase inhibitors of all types, alone or in combination with alpha blockers. And essentially what this suggests is that phosphodiesterase inhibitors, both alone and in combination, are superior to alpha blockers alone in terms of storage symptomatology improvement. A very, very important message, and one that I believe we'll start to hearing results regarding also in women in the very near future, again, because of improvement of blood flow related to the use of the phosphodiesterase inhibitors and the effect on bladder storage symptomatology. So for males, it's clear that combination therapy has become a very important aspect of the treatment of male LUTs. Certainly, isolated antimuscarinics are reasonable, but now many of us are using some combination of antimuscarinic and either alpha blockade or alpha antimuscarinic and potentially even phosphodiesterase inhibitors for the management of male LUTs. A similar algorithm exists for women and is increasingly being used to try to help symptoms. The problem is, what agents can we safely combine? And we are, as I mentioned, having increasing concerns regarding the use of antimuscarinic agents. A discussion regarding OAB would not be, and storage symptoms of the bladder and update would not be complete without discussing the aging bladder. And it's clear that the bladder is not like wine and cheese. It does not get better with time. And we understand that with age, with the passing of years, bladder overactivity increases, bladder underactivity increases, and these occur associated with an increasing incidence of comorbidities such as diabetes, high blood pressure, vascular inflow problems, blood vessel disease, such that patients have multiple problems that may result in bladder storage dysfunction. A variety of comorbidities now are being identified as being associated with overactive bladder, and we're all very much familiar with metabolic syndrome and the effects on bladder storage and urinary continence. We know that there's a relationship between certain central nervous system issues such as depression and serotonin disorders and bladder dysfunction. We know that there are a variety of bladder and bowel conditions that affect bladder storage and bladder emptying, both bladder pain syndromes and bowel conditions such as irritable bowel syndrome. We also understand that there are a variety of medical conditions, as I mentioned. And it is interesting to me that many patients now we're seeing with in the elderly age group are patients who appear to have subtle neurologic disease that appears to be affecting only the bladder. And there is now increasing literature suggesting that peripheral neurologic disease may actually selectively affect the autonomic system, especially in the elderly, leading to such things as the loss of bladder sensation, which obviously would then be directly related to the development of detrusor underactivity and even urinary retention. When we speak about refractory overactive bladder, it's again very important that we understand what we mean by refractory overactive bladder. And again, I guess the best way to put it is the patient is not satisfied with their condition as a result of any intervention that we have. These are a summary. The next few slides are summary slides of the treatment for refractory overactive bladder using a variety of agents. As you can see, the first is onabotulinum toxin. And these are the options and results that the European Association of Urology has come forward with, either for a refractory overactive bladder using onabotulinum toxin or sacral neuromodulation. And as you can see, the evidence is present. In some cases, it's not as good as we would like. And again, unfortunately, it's because many of our results, especially our neuromodulation results, existed before we understood how best to interpret patient response to therapy. Similarly, for sacral neural stimulation, again, these are results for refractory overactive bladder. The European Association of Urology essentially has said that sacral neural stimulation, nerve modulation, should be offered to patients with refractory urgency and urgent incontinence, refractory to conservative therapy. And again, what is conservative therapy? It's some combination of patient-controlled therapy as well as pharmacologic therapy. As I hope I've made clear, our understanding of pharmacologic therapy continues to evolve, and it may be that the overall definition of conservative therapy may continue to change as we move forward over the next few years and understand the complexities of long-term drug administration. What about refractory overactive bladder and the effects of various treatments for mixed urinary incontinence, MUI? And as we know, patients with refractory symptoms often have a combination of both stress and urgency symptoms. What the European Association of Urology has decided, and I'm very much in agreement with, the most bothersome symptom in women with mixed symptoms should be treated first. But again, the evidence is not very good for this. Patients with mixed incontinence are less likely to have surgical benefit than patients with pure stress urinary incontinence, and the evidence for that is very good. And patients with mixed urinary incontinence may not respond to a single treatment. Therefore, multiple treatments may be necessary. And again, this will impact patients' perception of benefit from treatment in that they may require multiple treatments to obtain some control of their therapy. And finally, refractory overactive bladder as influenced by age. It's very important. The European Association of Urology has basically stated that older women with urinary incontinence should be informed of the increased risks associated with any surgery, including onabotulinum toxin A injection, as well as neuromodulation, and there perhaps is a lower probability of benefit. And although the level of evidence is less significant, there is still evidence suggesting that older patients do not respond as well to our treatments for OAB that has been previously refractory to pharmacologic therapy. Why is this? Again, this may be to subtle neurologic degeneration of the bladder that comes as a result of the aging process. This is a very interesting paper, and it's one that I was fortunate to be involved in several years ago, that looks at essentially the focusing on the bladder and its if you will, initiation of the lower urinary tract symptoms, and essentially this brings together the structural and functional abnormalities that patients with lower urinary tract symptoms may manifest. And again, this is not only related to bladder muscular function, but also to urothelial and suburothelial space dysfunction, and also, very, very importantly, abnormalities of central function. And the abnormalities of central nerve function, as was predicted by Leonardo, remain our great frontier in terms of benefiting patients. So central function remains the area where we need to have better therapy and better treatment. I think neuromodulation is the first step to help with modulating input to the central nervous system, but clearly it is not the last by any means. So I'll conclude by saying that the development and treatment and understanding of lower urinary tract symptoms in both genders continues to advance very rapidly. We are beginning to understand not only better the effects of some of our treatments, but also, unfortunately, the side effects of some of our treatments, and that's especially true for the antimuscarinics. And we must be aware that in order to obtain the best possible treatment, we must understand what the patient is most bothered by and help that patient understand what is possible to obtain with therapy and what is not possible to attain. And I always leave my patients with the message that our goal is treatment improvement, but not cure. Cure is very difficult to attain. If we attain cure, we are all happy, but more than likely we are trying to obtain some level of symptom improvement, and hopefully that symptom improvement will be significant enough for the individual to be able to regain some aspects of their normal life and some of the things they enjoy doing. Thank you very much.
Thank you, Roger, and for this comprehensive lecture on blood management. And we have to skip the Q&As for this session, and we can move forward with the other two lectures on bulking.
Perfect. May I have my next lecture, please? Thank you.
Sure. It will be uploaded in a second.
Sure. So I actually have two segments, two parts to this next lecture. The first will be an overview of all bulking agents, and the last part of the lecture will be a review of a new bulking agent that I believe has just now become available in Colombia, which is called Bulkamid. So I will be happy to share this with you when we can.
Sure.
Okay,
There you go.
very good. Well, thank you very much, Mauricio. So, as I said, the first 20 minutes will be on bulking agents and whether or not we should incorporate them as first-line treatment for women with both stress urinary incontinence and mixed urinary incontinence. And as I mentioned in the prior lecture, many of our patients have mixed symptoms. And for those patients who have significant mixed symptoms, stress and urgency, I will often use bulking agents as my treatment for their stress symptoms as I simultaneously try to manage their overactive bladder symptoms because, again, surgery by itself, unfortunately, is not sufficient for many of these patients with mixed symptoms. So bulking is a very old method, and it has been used, as you'll see in a moment, for well over 100 years. This is a definition from the Cochrane reviews, which obviously are the English group who looks at interventions for everything that we do in urology. And the definition of bulking agents is the injection of materials into the urethral submucosa designed to create essentially an effect in the urethra like a cushion, like a sponge to increase resistance, increase urethral coaptation, and hopefully restore or at least improve continence. The mechanism of action is thought to be, this is a drawing of the urethra, and essentially this is the lumen of the urethra. These are the walls of the urethra, the muscular walls of the urethra, and this is the effect of the injection to create two, if you will, pads or pillows or if you will, areas where there is increased tissue that is improved by the bulking agent to actually close off the lumen without creating obstruction. So the goal is to increase resistance, increase leak point pressure, actually increase functional urethral length by increasing the mucosal coaptation, which is the term that's often used as seal effect, and improve the power of the urethral sphincter without causing obstruction. And that's the goal of bulking, and one that actually we try to attain with any material that we inject into the urinary channel for purposes of urethral coaptation. Why should we use bulking agents? Well, the agents are minimally invasive. It's essentially a needle injection. It can be done under local anesthesia and really should be performed under local anesthesia. The agents, you should not require general anesthesia for this treatment. It should be able to be done in the clinic setting. It should not require the hospital. It should be associated with low risk to the patient. It should be also associated with low risk of urinary problems after the injection, including both retention and also detrusor overactivity. And it should be suitable for women with multiple other comorbidities, such as diabetes and hypertension, who may not be a good candidate for surgical therapy. And then it also is something of interest to many patients because of the new mesh controversies and patients' concern regarding the possibility of mesh complications during incontinence surgery. What are the disadvantages of bulking agents? Well, it is well recognized that the overall efficacy is not at the level of mid-urethral tapes or retropubic procedures, but I will show you some interesting data in the next lecture regarding that. Before this time, there are limited long-term studies. Most of the studies are somewhere between 1 and 3 years of length. I will show you studies in the second part of the lecture which show much longer results. The length of time of effect is a problem with especially some of the older agents. So the term durability, the ability after injection for the effect to remain is not good for many of the older agents. There may also be complications associated with some of the agents, as you'll see in a moment. And some of the agents are more costly than other agents. So as I said, there's essentially now over a 100-year history of bulking agents, and you can see the first injection agents were actually wax, paraffin, which was described in 1904. Then a variety of other agents have been described over the years to the level of the most recent one, which is Bulkamid, which I will discuss on the second lecture. But you can see between 1904 and 2006, there have been multiple other agents that have been brought forward, and I will discuss some of them with you. Others I will not discuss. For instance, autologous fat was experimented with 30 years ago as an injection into the urethra. Fat was thought to be very good because it's the patient's own tissue. The problem with fat injection is approximately 70% of the volume of the fat is lost after injection due to lysis or disruption of the fat cell lining. Another agent that was thought to be very good initially was a combination of essentially a fluid carrier and something called hyaluronic acid, which is used for many indications in medicine. It was known as Zwidex. Zwidex initially was thought to have very good results, but over a very short time frame, it was seen to be associated with sterile abscesses of the urethra, which are very much a problem, and therefore was no longer brought forward after that time frame. Another agent that was associated with many complications was a liquid that became a solid at body temperature called ethylene vinyl alcohol. The name was Tegres. The problem with Tegres was it caused significant erosion of the urethra and therefore was also withdrawn from the market. So many of the agents are actually compared to the agent that historically has been the one that we have used the longest, which is collagen, a very safe agent, but one that loses much of its volume after injection. And so therefore, many of the studies that you will see historically done with new agents compared to collagen, as collagen is the one agent that until the recent time frame has lasted the longest. Collagen is no longer available now. It is no longer manufactured, but it was the agent that was historically used as the comparison agent for all other agents. This is a summary of the types of urethral agents that are available. There are cross-linked collagen agents, of which Contagen was one. There is also an agent called Permacol that I believe was only available in in Europe. There are a variety of agents that have small beads or particles in them. I mentioned Zwidex. You can see some of the others. Many of you may have experience with macroplastique or coaptite. These are very common, and these agents are liquids with a solid set of beads in them, and the beads are what remain after the liquid is reabsorbed by the body. There are also silicone elastomers, of which I mentioned Tegres, which had problems with urethral erosion. There's still an agent available in Europe called Urlastic, but again, the results long-term are unknown with this agent. And then there is something called hydrogel, and I will speak about hydrogel in the next lecture, which is now known as Bulkamid, which again I believe has recently become available in Colombia. So we know that there are variable results with the various agents. The effects are anywhere from 50 to 80% over time, and then we know that as we compare, in this case, Durasphere and collagen, over years, you can see significant loss of results between year 1, year 2, and year 3 if repeat injections are not required. And therefore, many of the agents have required repeat injections. And you can see the number of agents the number of percentages that are required for many of these agents to retain the values that were obtained after the initial injection. And as you can see, somewhere between 65 and 70% of patients attain results with the injection at 1 year. But with many of the older agents, those results are lost with time, especially a longer time frame, 2 and 3 years from the initial injections. So what are the optimal things that we need from a bulking agent? Well, we need the agent to be biocompatible. It should not cause any problems, including no immunologic problems. It should not be too thick to make it difficult to inject, and that's one of the complaints about some of the currently available agents. They're very difficult to inject because they're very thick. They should cause minimal tissue reaction. They should cause little inflammation, and what inflammation is caused should rapidly go away. The volume that is injected should remain. It should not be lost, and that's a major problem with many of the currently available agents. There should be a very low requirement of re-injection over time, and the material should be incorporated in the host tissue and regarded essentially as self, with no rejection or significant inflammation, as I mentioned above. There are two distinct current classes of agents, and the way to think of this are agents that are either non-particulate gels and those that are particulate combination gels. And I'll discuss the non-particulate gels in a few moments. I'll focus mainly for the time being on the particulate gels, which are not biocompatible. They essentially instigate a chronic inflammatory response, and their bulking effect is partially due to fibrosis resultant from that inflammatory response. And therefore, you get essentially a varying size of the cushion that's injected. And again, macroplastique and Durasphere are very common parts of this, as is coaptite. The homogeneous gels include collagen and Bulkamid, and essentially they are biocompatible. They allow integration of the host into the individual. They have very little degradation and migration and no adverse tissue changes with time. The problem with collagen is, and the difference between collagen and Bulkamid is that collagen had a fluid component to it, and that was approximately 50% of its volume. And so after collagen, at least half of the volume was injected almost immediately after injection. So that's the difference between those two particular homogeneous gels. So the particulate combination gels, as I said, are Durasphere, Deflux, macroplastique, and coaptite. And again, these agents cause calcification. They can be associated with erosion. This is a photomicrograph of essentially what the microplastique looks like, and as you can tell, it's a very irregular material after injection. So again, a very important distinction amongst these materials is the type of particulate materials that are being injected and what they look like after injection. This is Durasphere. These are the particles of Durasphere on the right slide. And as you can see on the left, the particles actually give the material a black color. But the material is black when the fluid is with it. You can see the fluid, which essentially is a material that allows the agent to be injected. It's a solution. And then after the injection, this dextranomer, which essentially is a sugary fluid, is lost. And all is left are these pellets. And these pellets are what form the bulking effect. And this is true for all the other microparticulate agents that are available. Durasphere versus collagen is very similar at 1 year, but as you can see, they both drop off at 2 years. And you can see the percent effectiveness after injection that drops off substantially both at 2 and 3 years, with less than 20% or less than 30%, and then under 20% of patients having effect from either of those agents long term. Macroplastique, as I'm sure many of you are aware and many of you use in your practice, is essentially polydimethylsiloxane, which is essentially a type of particulate material that is suspended in a bioexcretable carrier gel. It's a gel called PVP gel. It's injected with this particular type of injection tool, but it does require a gun to inject, and the gun is important because of the thick, viscous nature of the material that requires substantial energy to inject and is quite painful for patients, especially under local anesthesia. The results of the use of macroplastique as compared to collagen, again, as you can see, macroplastique has some preference, both in terms of improvement in overall activity levels and also in overall dryness. But overall, this was not statistically significant as compared to collagen in a 1-year trial that was evaluated in a relatively large number of women. The results and complications associated with this particular agent, macroplastique, are similar to what we see with all agents. And again, this is macroplastique versus collagen. As you can see, the most common side effects are urinary tract infection followed by dysuria symptoms, urgency after injection, and frequency, and then a much lower rate of everything else after that. And this is common for most agents that are injected per urethra. Infection, unfortunately, is very commonly seen. Dysuria and urgency are also commonly noted because of initial irritation and inflammation from the actual injection site. This is another macroplastique study that looked at a small number of women at 5 years. And as you can see, the overall success rate in those women was 73%. But that was only interesting enough. Of only 15 of the patients actually showed success. There was a significant urinary retention rate and also a substantial loss of the macroplastique over time per urethra. Coaptide is another particulate material. In this case, it's a calcium-based material. It is suspended in glycerin and carboxymethyl cellulose, which give it a liquid component. It is also difficult to inject, but not as difficult to inject as macroplastique. It has been compared to collagen. I looked at this many years ago, and it was very similar to collagen in terms of results, both in terms of cure at 1 year, as well as improvement in terms of activity levels, which is what this old methodology was. In terms of complications, again, as we noticed, complications were seen. A substantial number of patients experienced urinary retention with this particular agent, 40%, as you can see, as compared to only 30%, and this was short-term urinary retention. But still, there was an obstructive component associated with the injection of this particular material that we need to be aware of as we discuss the currently available agents that are used for injection technique. Urolastic, as I mentioned, is again one of the polydimethylsiloxane agents, very similar, if you will, to some of the materials that are used, especially like macroplastique. It has an ability to be seen under X-ray, so it does. This particular agent has a radiopacification that can be seen after injection. And in terms of retention, in terms of overall results, what's most significant is a delayed, as you can tell at 2 years, there's a delayed risk of erosion associated with this, which is problematic, which has caused many people to be worried about this agent for long-term use for urinary incontinence. This is another trial looking at that agent for women with recurrent urinary incontinence, and the overall success rate was only a third at 24 months, at 2 years, and of that third, approximately 20% were dry. So, interestingly enough, 4.5% of patients also had material that was extruded into the bladder. So, the overall complications were almost 1 in 4 patients had risks associated with urolastic, and therefore this agent is not available in many countries because of the complications associated with it. So, we've discussed quite a bit the particulate gels, which were the agents I've just been discussing. The non-particulate gels, again, include collagen, which is the historic comparator, which the only problem with collagen is it's a degradable agent versus Bulkamid, which is a non-degradable agent. And this is what I'll discuss in just a few moments. Collagen is a glutaraldehyde cross-linked material. It's made from beef collagen. It can be injected both with a rigid and a flexible needle. It does have an allergic risk associated with it. It did require refrigeration, and it was susceptible to biodegradation. This is a before injection and after injection collagen look, and again, the goal of all injectable agents is to increase the urethral bulk to essentially impede the lumen without obstruction, if at all possible. Collagen, as compared to, in this case, placebo, was demonstrated to be substantially beneficial, but as you can see, there is a decrease over time, both in terms of subjective and objective response, such that by 36 months, we are seeing less than around 40% of patients having response. And this was one of the concerns that was associated with collagen because of its biodegradation. Bulkamid is the other agent, and I'm going to give you now the second part of the lecture, which is the results with Bulkamid. Bulkamid is the new agent that I believe just recently became available in Colombia. It is a non-particulate, non-resorbable hydrogel. It's a 2.5% is the hydrogel and 97% is water. Now the water is part of the hydrogel though, so the water is not lost after injection. This is what the hydrogel looks like in terms of immediately after injection. And the most important story in these slides is that there is ingrowth of host tissues such that the hydrogel is incorporated into the host tissues and not extruded, or it does not lose volume. And these this is an ultrasound, as you can see, the bladder neck, and the injection deposits after the injection. And as you can see, these deposits can be followed long term, and they maintain volume over time. So there is a value to this particular agent in terms of volume retention, which obviously results in persistent bulk effect long term over time. So what is the clinical evidence for this agent? And one of the things that's important about this agent is the longevity of results. The longevity of results reported up to 10 years of data now has been shown to be very safe. And the European groups that use this have found it also to be very effective long-term, which is quite different than the other agents that we have available. So the Cochrane review, the Cochrane review was completed in both 2012 and 2017, and they felt that there was insufficient evidence for a recommendation for most of the therapies that were available. As you can tell, they looked at a variety of agents that were studied. And they said there was no therapy better than others, and there were significant complications noted with Zwidex and autologous fat. The Cochrane group just completed a new review, which was just reported at the British Association of Urology, which I was present at a month ago in Glasgow, Scotland. And the conclusion of that study, of that particular review, was that bulking agents should be considered an option for women with stress urinary incontinence. Unfortunately, they did not review Bulkamid, and so there were no statements regarding Bulkamid, which is the agent that I'm about to discuss. As you can tell, all other agents were discussed as part of this review, but not Bulkamid, which is the agent that we'll discuss. So this is an article. I was the medical monitor for this particular agent in the United States trials that have led to the consideration for FDA approval, which is ongoing at this time. And this was a 12-month study which was randomized, looking at the use of this particular agent, polyacrylamide hydrogel, known as Bulkamid, for women with urinary incontinence, either stress or stress predominant, in the U.S. and Canada. It was a large study. There were 345 women. And as you can see, of the patients who completed the study, the patients were compared to collagen, not to placebo. So there were 229 received Bulkamid, 116 were given Contagen. And overall, over 85% of patients, both in the Bulkamid and the Contagen trial, completed the one-year study, with follow-up being done at 3, 6, 9, and 12 months. And the primary endpoint was at least a 50% improvement in both incontinence, measured by the 24-hour pad test, and the overall number of incontinence episodes. So it was what's called a combined primary outcome. There were secondary outcomes, including overall subjective perception of benefit, and also change in baseline improvement in quality of life scores from prior to injection to one-year scores at the end of the injection follow-up. The efficacy and safety was evaluated in two relatively equal populations. This is the Bulkamid and collagen populations. They are, not surprisingly, women in their middle 50s. All were relatively thin women. No one was significantly obese. They had a long history of stress urinary incontinence. They had leak point pressures, all usually less than 100, but certainly mostly approximating 16 centimeters of water. They had low post-void residuals, and they had significant urinary loss over the pad testing that was done. And the overall incontinence episodes for 3 days averaged 3.3 episodes per day. So the primary endpoint was achieved as compared to Contagen. So the overall responder rate, so the dark bar is the Bulkamid, the light bar is collagen, and the overall patient subjective perception of improvement in last follow-up substantially differentiated, again, from non-responders. And as you can see, this was true for both collagen and Bulkamid. and that the incontinence episode rates at 12 months also were very similar in terms of benefit, with approximately 50% of patients obtaining no incontinence episodes at 1 year, which is really surprising. There have now been 2-year data reported by the European multi-study center looking at Bulkamid. This was 135 patients followed to 24 months, excuse me. They received a relatively small volume. About 1 in 3 did receive a second injection within the first year. And between baseline and 2-year follow-up, 89%, there was an 89% overall reduction in both volume of urinary loss and also frequency of urinary loss, which is a substantial improvement as compared to the baseline evaluation for the groups that were studied. Durability has been a concern, as I mentioned, with all of these agents. So this is the long-term efficacy at 5 years. This is a different group of patients studied, 256 patients done prospectively, followed from baseline to 5 years, 60 months. And as you can tell, this is the benefit in terms of improved or cured at 3 months post-injection, and that retention is almost unchanged at 5 years. And so, again, cured was completely improved, completely dry, and significantly improved was 1 leak a day or less. And again, these are individuals who had 3 leaks a day or more. So this is a substantial improvement over time as compared to baseline. The other interesting thing is, of these patients, 108 actually had mixed urinary incontinence. So these are the number of patients who had substantial improvement in their mixed symptomatology, again indicating the importance of stress urinary incontinence in patients with mixed symptomatology. The previous study was 5 years. This is a 7-year study looking at 352 women, almost 100 of whom had mixed urinary incontinence. Again, what this showed was that basically individuals, the definitions of outcomes were basically no stress incontinence with a stress test, and at least a 90% improvement on the patient's perception of outcome. Improved was only a small volume loss during stress test and a visual score of improvement of over 60%. And then you can see the failure results. This is the baseline data for these individuals. The overall results demonstrate at 7 years substantial benefit, cured and improved, as compared to failed over trial. So a very small percentage of patients failed. The vast majority had either cured or improvement, and this was retained over time, such that essentially approximately 76% of patients remained cured or improved at 7 years after treatment, with no significant side effects being noted in terms of long-term complications associated with this agent. This is another agent looking at essentially a meta-analysis of 767 women treated across 8 studies. And the overall success rates, again, there's variable length of time, but were approximately objectively 80% with subjective response of 90%. And equally important was a very low infection rate. Notice I had infection rates with the other agents of 20 to 30%. Notice the low infection rate in rates that were noted with no extrusions, migrations, or immune reactions, which were very, very important across various trials done at various centers across Europe and the Middle East. The safety profile is important to note, and it's very important when we consider risks with these devices to understand that balance against safety. And the most common side events, again, are that we are concerned are acute retention and urinary tract infection. And as you can see, those rates are essentially very, very low over time, associated with the historical rates that we've seen with bulking agents. And so from a safety standpoint, it does appear that this particular agent, Bulkamid, has both a very effective as well as safe profile. The newest data, which was just presented at the European Association of Urology, and this is very striking data, is what about an injectable versus a mid-urethral tape, especially when we're concerned about issues related to tape complications. And in the U.S., this is a very significant issue, as well as in the U.K. So is this agent safe as compared to mid-urethral slings? And If it is safe, is it also reasonably effective as compared to midurethral tapes? The patients basically underwent outcomes related to the two interventions. Primary outcomes were patient satisfaction, effectiveness, and complications. And secondary outcomes were changes in quality of life, pain during after treatment, and cost effectiveness. The agent was delivered with a consistent technique as compared to midurethral tape. There were 4 injection sites done with a specific type of a needle guide, and the volume over the injection sites varied to essentially between 0.2 and 1 millimeters total volume over all injection sites, and the injections were placed approximately 0.5 to 1 centimeter from the urethral junction. So in the midurethral, and this is the effect of the injection. You get, as you can see, a very nice, if you will, circumferential effect to basically close off the urethra for purposes of creating that cushion and coaptation. The results of that study showed that the midurethral tape was statistically significantly better, but only by a few percentages. So interesting enough, the bulking agent performed very well, and unrelated to the tape, there were no complications of note associated with the bulking agent as compared to the tape, and patient acceptances of the bulking agent was very high. This article is now in consideration for publication in the Journal of Urology, and so it's now providing us with data that the bulking agent is, while not completely equal, close to the results we get with midurethral tape without the complications associated with midurethral tape. So, should we consider urethral bulking as a first-line intervention or a second-line intervention? Well, what do patients want? And again, this is another trial done by the group at King's College looking at what patients would like from a patient preference standpoint. And given a choice, women will choose a less invasive procedure even if there is a lesser cure rate. And as you can see, these results are very, very powerful in terms of what patients would like. Patients prefer a clinical procedure which has essentially minor risk as compared to the major procedure. And this was 100 women, so this is very persuasive data. And again, allows us to consider the patient's choice in these options for the treatment of their both stress incontinence and mixed urinary incontinence. Of note, there are a variety of papers now that have been published, and some with quite extensive numbers of patients. And again, this was the largest, which is, again, the meta-analysis, which include almost 700 patients, looking at the number of patients who've received Bulkamid. There's now been greater than 20,000 injections with Bulkamid and no complications, again, as I suggested, with now greater than 10-year follow-up in many European countries. So in the UK, there's been multiple problems with midurethral tapes, and this is what's happening with bulking procedures in the United Kingdom. You can see the number of bulking procedures as they've gone up, and now many UK gynecologists and urologists are using bulking agents as their first choice of treatment because of the concerns regarding complications associated with midurethral tapes. This is quite a striking increase in the use of bulking agents in the UK, which is a relatively very strictly controlled surgical economy, as you know. Overall, stress incontinence procedures have dropped dramatically, and as you can see, the number of TVT, TOT tapes has dropped dramatically because of the issues associated with mesh complications. So again, this tells us why bulking is increasing, because there is less use of tape for the management of stress urinary incontinence. And certainly, as we compare the various other options for stress urinary incontinence, including a rectus sling or a retropubic suspension, obviously bulking remains a much less minimally involved procedure as compared to those procedures, and as we can see, is now preferentially being done to midurethral tapes, at least in the United Kingdom. So across Europe, essentially what we've seen, as I said, a substantial number of patients have been treated in over 25 countries with an 80% success rate, with more importantly, no significant long-term complications and no unforeseen complications occurring. The technique is standardized using a small 0-degree lens and a 4 injection port sheath. And again, the bleb itself, the volume of material remains stable over time, which is very important to the overall long-term results with the treatment. So obviously, when we discuss our options with patients, we should consider all options. For bulking agents, the ideal agent for bulking should be considered as a first-line option for women after pelvic floor exercises have failed. Obviously, it should be considered at the same time, if not before, surgical interventions. And obviously, we have to include our patient expectations must be observed and addressed both in terms of safety, efficacy, complications, and convenience for those individuals. So I'll conclude by saying that certainly this agent has now a long-term experience. I recently presented this data in Chile, and was a lot of interest in Chile, and I hope that you found this this presentation interesting. Thank you very much, Mauricio.
Thank you, Roger. I think we're going to move a little forward with the case because we don't have enough time, so we're going to take some questions from the audience. Yeah.
Estos agentes están idealmente no hechos, pero sí propuestos para incontinencia de orina.
Pasa en inglés mejor, o de una vez, o es la que traducir.
So I wonder if this kind of device, let's say bulking agents are for female incontinence. What about for post-prostatectomy incontinence? Is there any evidence talking about bulkamine? Evidencia acerca del bulkamine acerca de incontinencia post-prostatectomy.
You got the question?
I can't. The sound is very poor, Mauricio.
Okay, the question is so simple: is if this is available for female, is there any chance to have this for male as well for post-prostatectomy?
Well, Mauricio, I think it is a possibility. The results in males are not as mature, and I must say that we need more data before we can definitively say that it can be used in males. Certainly, we all are looking for an easy option for men, and I will say that the older bulking agents have not done well in men. Will this agent do well? Well, we are doing some trials now, and I hope we'll have that data. But at this point, I would say you should be really focused on women.
Okay. If we try to pick up something from these lectures and this symposium, what I think will be worthwhile to do as a doctors, aside from the fact that there are some concerns using what we usually use here in Colombia, which is the retropubic and TOT tapes. I think the message we can deliver is that we have to change the way we approach the patients regarding offering a procedure that we think works. Sometimes we're a little bit biased of what we think is the best we can do for them, but we never hear what the patients want, and this is something that is very important. How do you approach the patients nowadays? It is completely different from what you did in the past.
Yeah, Mauricio, I've always believed in starting simple and offering surgery as the last option, and the reason I do that because if surgery fails, what is our next step? And obviously, then we start talking about revision operations and complications and whatnot. So, I have always believed in offering bulking very early in the options for patients. I think many women are very interested in this because it can be done under local anesthesia in the ambulatory environment, and so I do think that women are interested in this. And I think certainly in the U.S. now, as in the U.K., we're seeing many women who are not interested in any surgery that involves mesh. And so this is a very nice option because of the long-term safety that has been shown with results that are not too dissimilar from what we have found with open surgery or midurethral types.
Okay, ¿alguna otra pregunta del auditorio? Okay, I think we're done. Thank you, Roger, again for being with us.
Thank you, Mauricio. I thank you so much, my friend.
From the United States, and thank you. We're looking forward to seeing you back again.
Hasta luego. Hasta luego.
Thank you.
Thank you. Bye-bye.
Bien. Vamos a seguir adelante con el programa. Adelante, Juan Ignacio. Muchas gracias a todos por la asistencia al simposio. Ya más adelante yo creo que vamos a lograr tener más información sobre el tema de agentes aumentantes. Están disponibles en Colombia. Como ustedes oyen, creo que es una alternativa más dentro de todo el arsenal terapéutico que nosotros tenemos. Pero creo que es importante tener en cuenta algo, y es esa decisión compartida que debemos hacer con los pacientes para la toma de decisiones. Habrá quien diga, yo sí me quiero montar en un procedimiento que así sea menos efectivo, eventualmente por ser menos invasivo, por no tener complicaciones importantes. Esa es la opción de tratamiento para mí como paciente, va a decir seguramente una mujer. Otra escogerá seguramente lo que convencionalmente vamos a ofrecer, así sea eventualmente que la decisión compartida con los pacientes más, digamos, nosotros podemos en este momento observar. Creo que tiene algún comentario.